Okay, is it live? Okay, good afternoon, everyone. I welcome you all to this channel for Manglal Global Nursing. Today we will be having our discussions on medical surgical nursing, and I hope that we will all have a very good time learning together. First of all, before we begin, I just want to start with a quotation. It talks about preparations. The best preparation for tomorrow is doing what you can do best today. So we will learn whatever we can today. We will give our best today. Okay. So we will go into the first question. The first question is in cardiac arrest. The first step in BLS is whether we will have to check pulse, start chest compressions, give adrenaline, or defibrillation. The first question is in cardiac arrest. The first step in BLS is check pulse, start chest compressions, give adrenaline, or defibrillation. So in this, we are already seeing what is actually BLS. Now, BLS is your basic life support, right? It is your basic life support. Question is already saying that patient is in cardiac arrest, so you will not be doing assessments. If it was check pulse, that would come under assessment. After doing the assessment, you would have already found out that patient is under cardiac arrest. Question is already mentioning that patient is under cardiac arrest. So the first thing that you will do is follow the CAB rule, that is circulation, airway, and breathing. So in this, we will give, the right answer will be, we will give chest compressions. Why are we not giving adrenaline? Why are we not giving defibrillation? As I mentioned before, we will be doing circulation, airway, and breathing, right? Defibrillation, we will not be using in case of cardiac arrest, right? Okay, let's look into the BLS algorithm 2025. We have new algorithm which has come up. I hope that it is visible to everybody. So firstly, we will be verifying our scenes, whether it is safe. We will be checking for responsiveness of the patients. We will be activating the emergency response system. Whenever you are present in a scene, you will check for scene safety. You will check for responsiveness. You will call for help. You will ask somebody to get an AED or a defibrillator. The thing to keep in mind here is there is an addition in BLS. It's no more a separate algorithm for opioids. So you will see that if, right, you're suspecting that the patient has gone under cardiac arrest because of opioid overdose, or you're suspecting any kind of opioid overdose, you will also have to give naloxone, administer naloxone if available. If not, we will be going on with our basic BLS, whichever is available, right? If you find out, you have to find out within 10 seconds, pulse as well as respiration. If the person is already breathing and the pulse is felt, we will wait, and we will wait until the advanced care arrives. But if there is only breathing and if there is no pulse, sorry, and only breathing, then we will give rescue breaths, right? One breath every 6 seconds or 10 breaths per minute we will be giving. Okay. We will check this every 2 minutes in case if there is no breathing, there is only gasping, okay? And pulse is not felt, we will go for CPR, that is your cardiopulmonary resuscitation. We will perform cycles of 30 compressions, 30 chest compressions, and 2 breaths. We will be using AED defibrillator as soon as it is available. If suspected opioid overdose is there, we will be considering your naloxone, right? Naloxone can be given intranasally, right? It can be given IM, right? And we will be waiting for AED's arrival. After the AED is arrived, we will attach the pads, right? And we will see whether it is a shockable rhythm or a non-shockable rhythm. The AED will prompt. If it is a shockable rhythm, then we will give shock and we will resume CPR immediately after the shock. When we're assessing the shock, we will not be touching the patient, right? And after that, if it is a non-shockable rhythm, then shock will not be given, but CPR will be continuing. Okay. Now let's look into adult foreign body airway obstructions, because sometime you're seeing that outside there is a choking case, right? Foreign body has entered the respiratory tract and they're having difficulty in breathing. So in this, you will verify the scene safety always. Check for signs of severe FPAO, weak or absent cough, unable to speak, change in color, cyanosis, or altered mental status, or any kind of apnea. If any of this is absent, we have to encourage for cough, right? We can ask them to cough, right? But if it is present, then we have to activate the emergency response team. Now, the thing that we should remember is, now we are not going to just start with abdominal thrust. Here, 2025 guideline says 5 back blows followed by 5 abdominal thrusts. We want to make it similar, like how we're doing in the pediatric age group, right? So we will be giving 5 back blows with 5 abdominal thrusts, right? Repeat until the object is expelled out or the adult has become if the patient has become responsive, right? If it has not become responsive, then what will happen is we will have to wait. If the adult is still unresponsive, start the CPR until advanced care arrives. Okay. And I hope that it is visible to everybody. We will be carrying on to our next question. What is the immediate intervention in pulseless ventricular tachycardia? What is the immediate intervention in pulseless ventricular tachycardia? So in this, what is actually pulseless ventricular tachycardia? It is the pulse is not present, the pulse is absent, and there is ventricular tachycardia happening, right? That is what in the ventricles, the heart is squeezing out too much, right? So it is going at a fast pace. So in that case, what will happen? There is 4 options: atropine, adenosine, defibrillation, and amiodarone. So what is the intervention that you will give in a pulseless ventricular tachycardia? For that, it has been given in the ACLS algorithm, right? In the ACLS algorithm, first we will begin with back and mask, right? Ventilation. We will start CPR, begin back and mask ventilation, give oxygen, attach to monitors or the defibrillator, whichever is available. Monitors, we want to see the patient, but when we are going to defib, we have to attach the pads there. We will check for rhythm. So shockable rhythms are VF and pulseless ventricular tachycardia. That is ventricular fibrillation and pulseless ventricular tachycardia. So the answer here, what is the immediate intervention of a pulseless ventricular tachycardia? The option is, the correct option is defibrillation. We have to give defibrillation for a patient who is having VF or pulseless ventricular tachycardia. So in the ACLS algorithm, that is your advanced cardiac life support, we will be following rhythm, whether it's shockable or non-shockable. Like shockable, then we will give shock and followed by immediate CPR, and at the same time we will be performing an IV and IOX, and after that we will assess the rhythm again. Okay, is the rhythm still shockable? Then we will be giving the shock and we will be following the CPR with epinephrine, right? So once 2 shocks have been done, we have given epinephrine every 3 to 5 minutes. Epinephrine has been given. Again, when you're assessing whether the shock will be given or not, after the 3rd shock, we will be giving amiodarone or otherwise lidocaine, right? So here the thing that we have to remember is your amiodarone. Your amiodarone is containing a high amount of iodine. So we have to keep that in mind. Okay, that this amiodarone is having a very high content of iodine. And what can it cause? So if the thing is having a lot of iodine, then what will happen is that it may cause long-term toxicity. So we have to watch for that, right? But in case of ACLS alone, it will not cause anything because we're going to give a dose of amiodarone, IV or IOXS. First dose will be 300 mg, second dose is 150 mg. Okay, lidocaine, the dose is 1 to 1.5 mg per kg, that is the first dose, and the second dose is 0.5 to 0.75. Some of the indications for your high quality CPR, as it's already given here in this chart, you will see that it is push hard, at least 2 inches, that is 5 centimeters, push fast, 100 to 120 per minute, and allow complete chest recoil, minimize interruptions in compression, and avoid excessive ventilation. If no advanced airway, use 30:2, right? We will be giving, if advanced airway is there, give one breath every 6 seconds. Okay. Now, for us to know whether our compressions, whether it is effective, the CPR quality is effective, it's very important for us to note capnography waveform, which is your ETCO2, whether it is low or decreasing, that it should not be below 40. Defibrillation in shock, biphasic, we will be giving about 120 to 200 joules. Of course, it depends on the manufacturer, the recommendation that is there. Monophasic, we will be giving 360 joules. We also have to remember these reversible causes. Reversible causes have been asked many times in our exams, like what will be some of the causes? Hypovolemia, hypoxia, hydrogen ion, that is acidosis, it will be present. Hypo or hyperkalemia will be there. Hypothermia is there. Tension pneumothorax, tamponade, cardiac tamponates, toxins, thrombosis, pulmonary, coronary, right? So we will keep that in mind. If no sign of return of spontaneous circulation, then we will go and we will continue with our CPR again. Okay. So that is about your ACLS. So the answer here, what is the immediate intervention in pulseless ventricular tachycardia? The answer is defibrillation. Okay. Number 3, we have drug of choice in symptomatic bradycardia. What is the drug of choice in symptomatic bradycardia? So what will be the answer? Bradycardia is heart rate below 60. So we will be giving which drug? That will be in symptomatic bradycardia. We will be giving the drug atropine. Okay. Atropine will be the drug which is given. Imidazole, I've already mentioned that it has high contents of iodine, right? And adenosine, we are going to use in case of supraventricular tachycardias when we're cardioverting, right? So we will be giving adenosine. As soon as we give adenosine, we will have to elevate the limb. Also give an IV fast. It should be given, adenosine should be given fast. It should be given along with 20 ml of NS bolus. And the last one is your lidocaine. So lidocaine also I've mentioned in ACLS we can give other than in replacement of amiodarone. Question number 4, it says the nurse notes that a client's ECG shows a whitening QRS complex. This typically indicates a delay in which part of the conduction system? The nurse notes that the client's ECG is showing a whitening QRS complex. This typically indicates a delay in which conduction system? So in the conduction system of the heart, we have this as the AC node. We have the AV node. We have the AV bundle. And we have Purkinje fibers. So AC node is going to trigger your electrical impulse and the electrical conduction is going to move on to your AV nodes. So before moving on, what is happening is that the entire atria has to be electrically excited. AC node itself, it doesn't need any stimulus from anywhere else to start that, right? So AC node is going to give the electrical impulse through the internodal pathways. These are the internodal pathways. And this is your Bachmann's bundle coming over here. So it's going to pass all of that. AC node is going to beat at 60 to 100 beats per minute, right? This is 40 to 60 beats per minute. And coming to Purkinje fibers, 20 to 40 beats per minute. So what you will see is that from SA node, it will come down to AV node and there will be a delay of 0.1 second, right? Because it's waiting for all the atria to fill up. After that, it will come down to your AV node. And from AV node, it will be carried by this fibrous bundle, which is known as your atrioventricular bundle. SA node, which is located in the top right quadrant of your right side of the heart, that right atria. AV bundle, it's going to carry your node, your electricity from the AV node, and it will travel through your left bundle branch, right bundle branch into your Purkinje fibers, which is going to excite the entire ventricles. So if you're looking into this ECG graph, you will see that P wave indicates arterial depolarization, which means it is contracting. P wave, it is because SA node is triggering and it is passing to AV node. Now in the AV node, I said there's going to be a delay of 0.1 second, which is indicated by this PR interval. Okay, it's coming into the isoelectric line. Next, when you're looking into the QRS complex, we have ventricular depolarization, that is the ventricles are contracting. So for QRS complex, when ventricular contraction is taking place, it is because the electrical conductivity has gone from the Purkinje fibers into the heart muscles, and it is one of the fastest traveling, right? It is one of the fastest traveling conduction system, that is the Purkinje fibers. It will pass its electricity. Because of that, we will have the pumping of the heart, which is going to take place. So the question is asking that whitening QRS complex, this typically indicates a delay in the conduction system of which part of the conduction system is typically delayed. If you're noting that in ECG, it is a QRS complex, the answer will be the ventricular conduction dealing with Purkinje fibers. Okay, I hope this is clear to everybody. A patient with, question number 6, a patient with metabolic acidosis due to renal failure will have which of the following? Increased pH, decreased HCO3, decreased potassium, or increased calcium. So if the patient is having metabolic acidosis due to renal failure, the patient will have increased pH or decreased HCO3, decreased potassium, or increased calcium. Let's look into the pH, right? The pH is 6.5 to 7.5. In a patient with metabolic acidosis due to renal failure, this is your pH. If you're looking into your metabolic acidosis, what will happen? Anything which is falling below your 7.5 range, right? That will be your acidosis. So patient, we are already saying that patient is having acidosis. So in this, what will happen is that will the pH increase or decrease? In acidosis, pH will decrease. In case of decreased HCO3, so here the answer is the patient is also having renal failure, so it will be decreased HCO3. I will tell you the reason why. Kidneys are normally supposed to, what are they supposed to do? They're supposed to excrete the H plus ion, and they're supposed to produce what? They're supposed to produce your HCO3. But here we already said that patient is having renal failure. So in a case where patient is already having renal failure, uh, patient is already having renal failure, so your HCO2 production is less and we are not able to excrete your H plus. So acidity is increasing, and whatever bicarbonates are available in the body, right, that's getting used up. The buffer is getting used up, and because of that, we will have decreased HCO3. Okay, so that is the answer. The others are all distractors. Question number 5. Sawtooth pattern on ECG is seen in. So when you're looking at an ECG, you are asked a sawtooth pattern on ECG. It is seen in atrial fibrillation, ventricular fibrillation, atrial flutter, or complete heart block. So there are 4 things: atrial fibrillation, ventricular fibrillation, atrial flutter, complete heart block. So in this, since I've already explained to you the conduction system from SA node to AV node, right? It's passing by. We're talking about these waves, right? The P wave. So P wave was what? It was because of the conduction between the AC node, the electrical impulse from AC node coming down to AV node. So what are we noticing in that is that it is the contraction of the atrias that's taking place, right? So here what we can see is that there are multiple P waves present, or we can say flutter waves. These are flutter waves. So why am I saying that there are multiple flutter waves present? When you're looking into the heart, what is going to happen in the heart is that there was the AC node, right? There is an AC node. It is passing the electrical conductivity, right? into the internodal pathways. This is your AV node, right? And it is also going to your Buckman's bundle. Right? It is going to your Buckman's bundle. So, if in case there is the blockage which is taking place here, right? A delay of 0.1 second, right? So when SA node is not the only one which is triggering, but some other external triggers are coming in, that re-entrant formation, like electrical impulse, when it goes in one direction. It always goes in one direction, but it's going back. This is also triggering, that is also triggering. There are multiple triggers taking place where it will form atrial flutters, right? What happens is that the heart rate will go above 350 beats per minute. Okay, so here this fibrous mesh which is present just before reaching your AV node, which is causing this 0.1 second of delay of the electrical impulse, will not allow this reentrant electrical pathway to pass to your AV node, right? And that's when multiple what waves are forming? F waves are getting formed before your QRS complex. Before formation of the QRS complex, multiple F waves which are presenting, it may be present in 2, 3, but it is regular pattern, right? So it will be atrial flutter. Sawtooth pattern on ECG is atrial flutter. Now let's look into the next question. The next question is Beck's triad. It is seen in, the Beck's triad is seen in pulmonary embolism, cardiac tamponade, left heart failure, or MI. So Beck's triad, it is seen in pulmonary embolism, cardiac tamponade, or left heart failure, MI. So the answer is your cardiac tamponade. Thing to remember in Beck's triad, what are the 3 Ds that you have to remember? The 3 Ds are distant or muffled heart sounds, right? Decreased BP, distended neck veins. Distended neck veins. This is your increase of jugular venous pressure, JVP. Okay. So in Beck's triad, it is seen in cardiac tamponade. First of all, what is cardiac tamponade? Cardiac tamponade, your cardiac tamponade, it is the heart. If suppose, let's say this is the heart, it is being covered and protected in a sac. What is this sac called? Pericardial sac, right? So the pericardial sac, what happens is that there are fluids, let's say, any kind of pus, let's say, right? It does have a normal amount of fluid, like 10 to 15 ml, but if it is beyond that, this heart will not be able to expand, neither is it able to, it's not able to, there is nothing to squeeze out, right? Difficulty in contraction and expansion. So what will happen is that this thing will cause your distant heart sound. Distant heart sound or muffled heart sound. When you talk about distant heart sound or muffled heart sounds, by that I mean, if you're under a swimming pool and you're clapping your hands, the sounds that you hear will be different. It will be muffled, right? So in the same way, the heart sounds will sound like that. There will be a decrease in BP. Why? Because heart is not able to fill up. As I said, that what expansion of the heart will not be able to take place because pericardial sac itself is filled with fluids or otherwise pus, right? So it's not able to expand. So in that case, they are not able to fill with proper amount of fluids. So when the blood is not, when the heart is not able to fill in with blood, what will happen? There is very less blood. What will the heart pump out? The heart is not going to be able to pump out anything, right? And so we will, and whatever blood is trying to enter the heart, that also will be blocked, right? So because of this, we will have distended neck veins. The neck veins will start dilating, right? So Beck's triad, it is seen in cardiac tamponade. Question number 8, it's talking about most sensitive marker for myocardial infarction. Okay, sensitive marker for myocardial infarction. injury to the muscle of the heart, right? Myocardial infarction. So what test will you do first? So CKMB test, which is present here, it is sensitive between 48 to 72 hours, right? This is going to show you if there is any kind of damage in the myoglobin, right? Myoglobins are very much associated only with myoglobin is your muscle cells, right? Tropi, your troponin, it is a protein specifically only present in the heart, right? LDH, no, the answer is not LDH. Myoglobin, no, as I mentioned before, it is muscle cell. It is found everywhere. If there is a damage in the liver, in the bones, in the kidneys, right, your myoglobin will show. But we want something specific to the heart, so the right answer is troponin I, which is elevated to 10 to 15 days in the blood, right? So we will do troponin I. Now let me give you a scenario. In case the patient is admitted with MI and you want to know whether the patient had a second chance of MI or whether cardiac arrest happened in hospital again after seeing the symptoms, the test you will go for will be CKMP, right? Because it's elevated 48 to 72 hours, right? So this is about your myocardial infarction. A patient on dialysis develops hypotension during the procedure, right? A patient on dialysis develops hypotension during the procedure. Immediate nursing action. What is the immediate nursing action? Patient is on dialysis, developing hypotension. That means your BP is decreasing. What will be the immediate nursing action? Will you increase the dialysate flow? Will you stop dialysis and give saline? Will you give antihypertensive or will you restrict fluids? So whenever dialysis is taking place, the fluids are getting drained, right? Will you restrict fluids? So you will not restrict fluids, but what would you do? But is it specific to your hypertension? We will stop the dialysis and we will give saline. Okay, we can put the patient in Trendelenburg position, right? That will be the head portion will be low and the legs will be elevated, right? This is your Trendelenburg position. We will not be giving antihypertensive if patient is already having hypotension. We will increase the dialysate flow. We will not increase the dialysate flow. We can decrease the temperature of the dialysate, right? But we will not be increasing the flow. Okay. Okay. Coming to nephrotic syndrome. Nephrotic syndrome is characterized by 1 gram protein per day, loss of 1 gram protein per day, more than 3.5 gram per day, hematuria or oliguria. Which one is it? Nephrotic syndrome, it is characterized by loss of more than 3.5 gram per day. Okay, so protein is getting lost, so you will have to replace the protein in moderate amount. It's not like you're giving the patient more and more protein, but it should be given in moderate amount. And the treatment that we have to remember is we will also be giving drugs like corticosteroids in nephrotic syndrome, right? We will have to monitor, specifically, we will have to monitor the weight, okay, the weight of the patient. Same time, same clothes, right? We will not be changing. It should be the same clothes. It should be at the same time, right? So we will be monitoring that. Also, we will be checking for abdominal GERD. Why? Because there is high chance of ascites, right? So abdominal GERD, we have to check if there is any kind of abdominal fluid collection, right? So we will be doing it at the level of the umbilicus, okay? This is about nephrotic syndrome. Next, we have when assessing a patient with pneumothorax, which finding is most characteristics? What is pneumothorax? Pneumothorax is air in the lungs. In the lungs, if you see the chest X-ray, it will be white. It will be white in color, right? The opacity. So which finding is most characteristic? A, is it increased breath sound on the affected side? B, is it tracheal deviation towards the affected side? C, is it hyperresonance on percussion of the affected side? Or D, symmetrical chest expansion? Which one will it be? Patient is having pneumothorax, that means air in the lungs, right? So will it have increased breath sound? When there is too much air in your lungs, then already what's happening? The lung is getting collapsed. The lung is getting collapsed. So what will happen? Will you have increased breath sounds? No, there will be absent breath sounds, right? Tracheal deviation, will it be towards or away? It will be away from the affected side, right? Because how come tracheal deviation will be away if this is your trachea and these are your lungs? And let's say that in this part there is pneumothorax, the pressure is going to build up and your trachea is going to deviate away from the affected site. Hyperresonance on percussion, this is the correct answer. Percussion में hyperresonance will be present. One reason why hyperresonance will be present is because since it is filled not with fluid, it is filled with air. So if you beat a drum, there is a sound, right? Because there is only air inside. Similarly, in the lungs, when it is filled with air, you will hear a hyperresonant sound. Symmetrical chest expansion will be present. No, this is not the correct answer. Okay, so this is about your pneumothorax. Immediate intervention may be required. In some cases, we have to supplement with oxygen. We have to manage, at least make sure that the SpO2 level is coming up till 92%. We want to maintain that, right, in pneumothorax. Now, next question, we're seeing about lymphocytes. T lymphocytes are involved in humoral or antibody-mediated immunity, cellular or cell-mediated immunity, both of these, or they do not produce immunity. So which one is it? They do not produce immunity? Definitely not. It cannot be two of it, right? It is cellular or cell-mediated immunity. T cells, they are involved in cellular or cell-mediated immunity. This is very specific to their targets. Okay, very specific to the target. They don't produce antibodies, do not produce antibodies. Okay, they attack only the specific area where they need to go and attack. Okay, and they will not produce antibodies. Humoral or these are your T lymphocytes. Okay, so T lymphocytes, the signal will go up to where? The signal will go to medulla. Okay. Here, when a patient is receiving high-dose intravenous corticosteroids for asthma attack, what must the nurse monitor? Patient is receiving high-dose intravenous corticosteroids. So for an asthma attack, what must the nurse monitor? Whether they will have to monitor blood glucose level, causing hyperglycemia and potassium levels, or creatinine and bun, hypoglycemia and hyperkalemia, all the above. So when we look into it, we always know that corticosteroids, what happens is that they increase the glucose metabolism pathway. They will increase your glucose output. Okay, let's put it that way. So it will cause hyperglycemia. Okay, and potassium levels will drop, causing hypokalemia. It will cause potassium levels to drop, causing hypokalemia. Next question. A client's renal calculi are identified as consisting of calcium phosphate. Which of the following diets would be appropriate? A client's renal calculi. What is happening? There is stone in the kidney, okay, consisting of calcium phosphate. Okay, the thing that it is made up of is calcium phosphate. Which of the following diets would be appropriate? Now we want to give, since it's already calcium phosphate, we will be giving low calcium and low phosphorus, right? And acid ash. This acid ash diet will be following, which means we want to increase the acidity level, which is going to break down the calcium phosphate. So this you will find in any kind of legumes, right? If you eat eggs, right? And if you eat fish, poultry, right? So you will get the acid ash diet. So we want to maintain the diets which has low calcium and phosphorus. Which diagnostic test is considered the gold standard for diagnosing pulmonary embolism? So what is pulmonary embolism? Pulmonary embolism, it is blood clot, right, present in the lungs. So the diagnostic test, which is the gold standard for diagnosing pulmonary embolism, is it chest X-ray? Is it D-dimer? Is it CT pulmonary angiography or electrocardiogram? Chest X-ray, we do chest X-ray, but it may not be visible in the chest X-ray, right? So this is not the gold standard. D-dimer, yes, we do it, but it is also not the gold standard. We will be doing CT pulmonary angiography, right, which will give us the exact location, the diameter, the size, right, where it is blocked, right? Electrocardiogram, no, we are not doing it, right? Which of the following is a primary nursing responsibility when caring for a patient with a chest tube? Primary nursing responsibility, the patient is having chest tube, right? We're inserting chest tubes for any kind of pneumothorax, right? So milking the tube every 2 hourly to prevent clots. Will you milk it every 2 hourly, right? Will you strip the tubing, right? Or you will keep the drainage system below the level of the chest, clamping the tube when the patient is ambulating. Ensure the suction control chamber is bubbling rapidly. So none of these are the answers. The thing is keeping the drainage system below the level of the chest so that the drainage will be taking place. A nurse is providing education to a patient with hypertension about the function of baroreceptors, right? Where are these receptors located? Baroreceptors, we will sense your the volume, right? So they are very specific. So it will be present in the carotid sinus and the aortic arc, right? When the heart is if this is your heart, your aortic arc is passing by, right? And your carotid sinus. So it will be present in your carotid sinus and aortic arc, right? Baroreceptors cannot be in the kidney. We are not going to measure any of the volume input that's there, right? In the right atrium, there are other receptors, but it is not a baroreceptor. Okay. So when administering digoxin to a patient with atrial fibrillation, which electrolyte imbalance most increases the risk of toxicity? You are administering digoxin to a patient with atrial fibrillation, electrolyte imbalance causing increased risk of toxicity. The answer will be, what will cause increased risk of toxicity for this? It is hypokalemia. Okay, the answer where digoxin to a patient with atrial fibrillation in electrolyte imbalances will be hypokalemia, right? The patient with hypertensive crisis has a BP of 240 by 130 mmHg and a sign of confusion. IV nitroprusside is ordered. Which action is most important for the nurse to take? The BP is 240 by 130. This is a hypertensive crisis we're talking about, and IV nitroprusside is already ordered. Which action is important for the nurse to take? Titrate the infusion to lower BP by no more than 25% in the first hour. Lower the BP to normal range immediately. Place the patient in Trendelenburg position or give oral antihypertensives. We will not be giving antihypertensive. We don't want to increase. We will not be putting the patient in Trendelenburg position, right? We will not lower the BP immediately. We don't want that, right? We want it to gradually come down. So we will titrate the BP no more than 25% in the first hour. The last question for today is earliest manifestation of fluid overload. What is the earliest manifestation of fluid overload? The earliest manifestation, is it pulmonary edema? Is it peripheral edema? Is it weight gain? Is it raised BP? So the answer is, as we have mentioned before in the nephrotic syndrome, also we said that we will be monitoring weight, right? So here too, in fluid overload, we will be checking weight gain of the patient. At the same time, we will be measuring the weight, right? Because this will be the first changes that will take place once weight is gained. Gradually, what you will see is that peripheral edema, pulmonary edema, all these things will increase, right? So that's all for today's session and discussion on some of the MCQs from medical surgical nursing. I hope that we're all able to understand, and we will see you in the next class. Thank you for your patient listening.